Before we start today's episode, I want to start with a trigger warning because we're going to be talking about pregnancy loss and miscarriage today. I want to acknowledge that this is a sensitive topic. It may bring up strong emotions for some listeners. If at any point you feel the need to pause or take a break, please do so. If you remember nothing else from this episode, please know that this is not your fault and that a miscarriage is not the result of something that you did or something you didn't do. And that even though there's always a risk that a pregnancy can end in a miscarriage, the chance of your next pregnancy being successful and going on to produce a healthy baby far outweighs your risk of miscarriage in the future.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
In today's episode, we are going to be talking about miscarriage. We're going to discuss how to manage a miscarriage and what happens after. We're also going to answer some of your common questions about miscarriage. To learn about the symptoms, diagnosis, type, and causes of miscarriage, check out episode 43. Your doctor has just confirmed that you've had a miscarriage. What's next? First of all, we're so sorry for your loss. And it's okay to feel whatever you're feeling right now. It is okay to grieve. Miscarriage is the loss of a dream, the loss of an idea. We know that both women and men connect to a pregnancy the moment that they know the pregnancy has been established, whether this is a pregnancy as a result of fertility treatment or whether it is a spontaneous pregnancy. If it is a wanted, loved pregnancy, the miscarriage can come with a tremendous amount of grief. And sometimes it's difficult to talk about it. Sometimes it's not socially accepted to talk about it or to grieve with the same intensity as it is socially accepted to grieve other types of losses. But I think it's important to know that it is still a loss and it deserves space for grieving. From the perspective of your body's health, first of all, it's important to confirm that everything has passed. Why is this? Well, retained products of conception, or RPOC, is a term that we use that refers to tissue that remains in the uterus after a pregnancy has ended. This can be placental fragments or fetal tissue. So why are retained products of conception concerning, and why as fertility specialists we work so hard to make sure that our patients have good active management of retained products of conception? Well, one is the risk of infection. Retained products can become infected, leading to serious condition known as endometritis, and more rarely, if really left untreated, it can lead to something more serious like sepsis, which could be life-threatening. It can also cause prolonged bleeding, so women with retained products can have spotting or heavy bleeding or periods where the uterus is on and off. And of course, this could be very stressful, but also over time can lead to complications such as anemia. Retained products also prevent the uterus from recovering back to its normal state. So it's going to delay the physical recovery and the return to fertility, which is really important after having a miscarriage. Furthermore, it can cause cramping, pain, which, of course, we want to get you back to your best self, to your stronger self, so that you can continue on your fertility journey. Untreated retained products of conception in severe cases can lead to scarring of the uterus or a condition called Asherman syndrome. This is a serious complication which can have a very negative impact in your ability to conceive in the future. As fertility specialists, this is one of the complications that we try very hard to avoid at all costs. To go back to your original question, how do you confirm that everything has passed? All the tissue has now left the uterus. So most often this is done via ultrasound. Generally speaking, here at Markham Fertility Center, we will do an ultrasound about 2 to 3 weeks after the heaviest bleeding. If an ultrasound is done sooner,
it can be really difficult to distinguish between pregnancy tissue and blood clots. And it can lead to very unsatisfying answers when really there is no answer, and we just have to do a repeat scan. Occasionally, your physician may order a pregnancy hormone level or a beta HCG as well, especially if the pregnancy was very small and it was too small to be seen on ultrasound. In regards to types of miscarriages, you can check out episode 43 where we go into them in detail. If there is a complete miscarriage, meaning that there's no tissue left behind in the uterus, then no further medical treatment is needed. If there's a missed miscarriage or an incomplete miscarriage, then we do need to consider further treatment options.
So let's talk about the treatment options for incomplete or missed miscarriages. One option is what we call expectant management. That means that we're not doing medical treatment, we're not doing surgical treatment, we're waiting for the body to complete the miscarriage. This is an option if we're looking for the body to pass the miscarriage naturally, which unfortunately can take quite a few weeks. This is really not our preferred option for a number of reasons. One of the reasons is that it can be very unpredictable on when it's going to happen. So you can go with no bleeding for weeks and then all of a sudden you might be out. You could be traveling and then you're having a significant bleed. It could be severe enough that you need to go to the emergency room or would at least interfere with whatever activity you're doing. Psychologically, it's very hard to be thinking every day, is it going to happen today? Is it going to happen today? So most of our patients in the fertility clinic really don't elect to do the expectant management, and we offer it as an option, but it's not something that we recommend, and that's one of the reasons. Another reason that I am not a big fan of expectant management, besides the fact that it's unpredictable and it can happen at any time, is that there is a very small risk of infection as well, because the pregnancy remains in the uterus for a long time without active management, in addition to what I mentioned, that it's psychologically really stressful. Not only are you wondering if it's going to happen every day, but also you're not able to really move forward. The miscarriage happened, you know that your dream has ended, but yet you're technically still pregnant and can't really plan for the future, which can lead to feelings of being stuck, which can be very difficult on top of the grief associated with a miscarriage. Now, expectant management might be a good option if the miscarriage has already started. So let's say you get diagnosed with a miscarriage. The next day, you start having cramping and bleeding. Then it's reasonable at that point not to take the medications and then just wait for the body to pass, because the cramping and the bleeding is a sign that the body has already gotten the message that it needs to pass the miscarriage. So expectant management is a reasonable option when there is a good indication that the body is already doing that. Regardless of whether the body's already doing it or not, it is important to set a time limit for expectant management. We're okay giving you a couple of days to a week, but we certainly wouldn't want 3 months to pass by and we're still waiting for a miscarriage to happen naturally.
Apart from expectant management, we also will discuss medical management. Medical management is most often done by a medication called mifepristone. This is actually a combination treatment composed of 2 drugs called mifepristone and misoprostol. Now, mifepristone is fairly new on the Canadian market, and prior to the introduction of this medication, we were using just misoprostol in the treatment of miscarriages. Mifepristone is a medication that can be used in pregnancy up to about 9 weeks gestational age. This medication is actually free in Ontario pharmacies if you have a valid OHIP card. It does require a prescription. The medication comes in one box that contains 2 boxes with 2 different medications. Mifepristone is a, quote, anti-hormone that works basically by blocking the effect of progesterone, which, as we know, is a hormone that is needed to help support an early pregnancy. So this medication is just a regular pill, meaning it's just a pill that you take by mouth, you swallow with a sip of water. After you take it, some women may experience a little bit of vaginal bleeding, but you may feel absolutely nothing, not have any bleeding or any cramping, and that's totally okay. After 24 hours, you would take the second medication. Again, this is the medication called misoprostol. Misoprostol, or miso, causes the uterus to contract and the cervix to soften and open. And this causes any tissue that's inside the uterus to pass through the cervix and out the vagina. Now, with Mifekai Meso, you take the misoprostol by holding the tablets in your mouth, between your cheek and your gums for 30 minutes. Any fragments that are left there after 30 minutes can be swallowed with a glass of water. Cramping and vaginal bleeding will often start within a few hours of taking this medication. And you can expect heavy vaginal bleeding, which may include large clots for the first 12 to 24 hours after taking this medication, but it really should slow down over the next several days. The cramping may feel similar to menstrual cramps, but it's often much more intense. You may also feel some nausea, and again, very common. You may even experience some vomiting. You may also have diarrhea. These symptoms happen because as the uterus is contracting, the bowels are close by and they can become irritated. You can experience these GI symptoms. When somebody takes misoprostol, you can also feel flushed or even feverish, and this is a side effect of the medication. So it's important to note that this is not a true fever, that this is not a sign that you have an infection, but this is a side effect of misoprostol and it passes after a few hours. After taking misoprostol, you can expect bleeding or spotting to continue for up to a total of 7 to 10 days.
Now, let's talk about some of the things that we advise our patients to do when they're taking this medication. In preparation for taking the second medication, the misoprostol, we advise that you're home. You could be working from home if you need to, but ideally, I wouldn't want my patients to be out in a concert or out in a mall, or even if you're home hosting a big family event or anything like that, because like we mentioned, there could be a lot of pain, cramping, and bleeding. And you want to be able to be home and comfortable with that, ideally together with a loved one. You should have pain medications at home. Over-the-counter medications that you can use is Tylenol or Advil. Our physicians here at Michael Fertility Center can also prescribe Tylenol 3 if you're not allergic to codeine in addition to the medication. You can also have Gravol, which you can buy over-the-counter for nausea. You can have heating pads. Those are very good for when there is uterine cramping. Make sure that you have sanitary pads, especially the big ones, because the bleeding can be quite heavy. You might also want to have some of the pads that you put in the bed or in the couch as well if you're going to be lying down. I mentioned that ideally somebody would be home with you in case that you feel lightheaded or the bleeding is too much and you feel that you need to go to the emergency room.
So when should you seek emergency medical attention? This is really important. If you're having very severe, very sharp pains that are not relieved at all by Tylenol or Advil, that would be a reason to be assessed by a physician. If you're having a fever, having chills, or foul-smelling vaginal discharge, that would be another reason to get checked out by a doctor. If you have very, very heavy bleeding where you're soaking more than one sanitary pad in an hour, and that's continuing on for more than 2 to 3 hours, that would be another reason to be checked out by a physician. Now, if you're experiencing vomiting that does not resolve within 6 hours, and if you're unable to keep down any fluids, we would also suggest going to the emergency room. If you're fainting or if you're feeling very dizzy, then that would be another reason to go to the emergency room. And of course, if you're just worried or concerned, or if you're just not sure, these are all excellent reasons to go to the emergency room because it's always better to be on the safe side and be checked out by a physician to make sure that you're doing okay.
It's important to know that every miscarriage experience is different. I know many patients Google symptoms and they think, oh, I didn't have as many bleedings as I was supposed to, or I had more bleeding than I was supposed to. So just know that every experience is different. I've had a couple of miscarriages myself and they were all different in terms of the pain and the bleeding and how quickly everything passed. If you have questions, know that here at Michael Fertility Center, we're here to support you. We know this is a very difficult experience. We want you to know that you're not alone. Every miscarriage is different, so you're probably going to have a lot of questions, and feel free to contact your nursing team if you have any questions about whether the cramping or the bleeding that you're experiencing is normal or not. Our nurses answer the phone or emails during business hours, but we also have an after hours line. At the time of recording in August of 2024, the hours for that line is until 8 p.m., 7 days a week.
So how effective is medical management of a miscarriage? What's the evidence?
There was a very large study from 2018 that was published in the New England Journal of Medicine, where they found that after women took misoprostol only, 67% of women completed their miscarriage, meaning all the tissue has passed. But when women took a combination of the mifepristone and misoprostol, or mifegymiso, 84% of women had all the pregnancy tissue pass. It's important to note that in this study, patients returned for reassessment about 1 to 4 days after they took the misoprostol. And this is actually a pretty short period of time. Certainly, we see patients who may continue to bleed and pass tissue for even 7 to 10 days after taking misoprostol. And so the numbers are actually probably higher than what they are seeing in the study if they had followed them out for a little bit longer. There was another study from 2020, which was a randomized control trial by Chu et al. And again, a randomized control trial is considered a very strong level of evidence. And in the study, they had about 2,600 women. When women took a combination of the mifepristone and misoprostol, 87% of women passed the pregnancy tissue. What's more interesting is that they found that the risk of infection, the duration of bleeding, or the need for blood transfusion, there was no difference between taking mifepristone with misoprostol or misoprostol alone. On the topic of management of miscarriages, we have so far covered expectant management and medical management. Another option for managing miscarriage is what is called a DNC, or surgical management. Surgical management means a procedure where a physician is physically removing the products from the uterus. The way that this is done depends on the clinic that you're working with. In some clinics, it's done at the fertility clinic with a little bit of sedation, and in some other places, it's done in a hospital setting with anesthesia, and that's what we generally call a DNC. Here at Markham Fertility Center, we are affiliated with Markham Stouffville Hospital, and we work very closely with the amazing group of obstetricians and gynecologists at Markham Stouffville Hospital. So our patients have the ability to have a surgical procedure, a DNC, in the hospital under anesthesia performed by the obstetrician gynecologist on call. The process here at Markham Fertility Center would be your fertility specialist, and you will discuss whether a DNC or surgical management is the right treatment for you. If that is the case, we would get your OR paperwork done, which includes your consent forms. And then you go to the hospital and register. Very important to have nothing to eat or drink because of the anesthesia that will be provided. And once you register at the hospital, you're put on the OR list on call. This means that you don't have a specific appointment for when your procedure is going to happen. You are on call for the operating room, so it might mean that you're waiting many hours before the procedure can be completed. Very rarely, the operating room is so busy that the procedure cannot be completed and you might ask to come back on a different day. So while the procedure will be discussed with your fertility specialist, and your fertility specialist is going to discuss the risks of the procedure and complete the process of informed consent, the actual procedure is performed by the obstetrician gynecologist on call at the hospital, who you may have never met before. Some of the risks associated with the DNC would be the risk of the anesthetics, which would be fairly small if you're otherwise healthy. There is a risk of bleeding, infection, and perforation of the uterus. Another significant risk is the risk of scar tissue formation, or something called Asherman syndrome. The risk of Asherman syndrome increases with the number of DNC procedures that you do, but it is still significant with just one DNC, as high as 10%. Asherman syndrome basically means scar tissue in the uterus where the two walls of the uterus adhere to each other and a scar is formed. In order to fix Asherman syndrome, you might require a second surgery called a hysteroscopy to remove the adhesions. Sometimes Asherman syndrome can be very severe, leading to so much scarring of the uterus that it cannot be corrected. And of course, this would be a problem for future pregnancy. Those are rare events, but certainly Asherman syndrome is a condition that sometimes can be difficult to treat. And this is one of the reasons why we prefer medical management of miscarriage to avoid the risk of Asherman syndrome, even if you're only having one DNC, which is part of the problem because when we're seeing a patient with a miscarriage, we don't know if this is the only DNC they're going to have or if they're going to require more surgical procedures down the line. So we try really hard to minimize any surgical procedures to the uterus for this reason. Retained products of conception can also happen when you're doing a DNC, but the risk of retained products are much smaller in a surgical procedure. So we've talked about expectant management with miscarriage. We've talked about medical management, specifically with MIFI-Guy-Meso, and we've talked about surgical management in a DNC. But what does the evidence say? Which method is best? There was a 2018 study. It was a systematic review and a meta-analysis. This is where they took a bunch of trials. In fact, they took 46 trials and combined them all together and looked at 9,250 women and their experiences. Several conclusions came out of the study. They found that expectant management had lower effectiveness for getting the tissue out of the uterus. And this is really not surprising, as we talked about. Expectant management had the highest chance of needing further treatment. In terms of medical treatment and surgical treatment, they found that the effectiveness, meaning the likelihood that the pregnancy tissue would pass, was actually quite similar. They also found that the side effects that people experience were very similar across all of the options. They found that fewer people needed pain medications after surgery compared to medication. Again, this is really not surprising because when you think about it, during surgery, a person is going to be asleep or they're going to be anesthetized while they have the bulk of the tissue being brought out of the uterus. And so when they wake up, there's a lot less contracting of the uterus because there's less tissue, if there is any, that the uterus needs to pass. So again, it's not surprising that people would need more medications when they're going with the medical management as opposed to surgical management. In the study, they also found that surgery had the lowest likelihood for post-treatment infection and serious complications. And it also had the highest likelihood for post-treatment satisfaction. This is absolutely true in the short term, and this absolutely makes sense. But when we're thinking about things from the perspective of a fertility doctor, the severity of the complications also really matters. Although the risk of retained tissue or RPOC is going to be lowest after a surgical intervention, the impact of intrauterine adhesions or uterine perforation is so much bigger, especially for a fertility patient. If there are retained products of conception, if there is tissue still left in the uterus, that is something that we can recognize quickly with our regular ultrasounds, and it's something that we can deal with, whether it's trying medication again or whether it's moving to surgery, but knowing that we've at least tried medication to reduce the risk. When we find a patient who has intrauterine adhesions, that is a really, really difficult thing to treat. And as Dr. Garcia said, this may require a second repeat surgery. And even then, there's no guarantee that the lining of the uterus will recover from the trauma. And when we're thinking about our patients in the context of fertility, we're always thinking about future fertility and the risks associated with future pregnancy. So from our perspective, medical management really carries the least risk to the uterus and the least risk of negatively affecting future fertility. And this is partly due to the fact that we have such a great follow-up system, and we do very close follow-up after patients who go through medical treatment. We scan patients early and we follow up with them often. So the risks of infection or the risks of people having retained tissue is really low because we have a good system in place. And so that risk of infection is even lower in our experience than it was in these studies. This is the situation of the short term versus the long term, right? If you're just looking at what's going to get it done faster, sure, a DNC might be the thing because, you get a diagnosis today, the next day you go through surgery, the day after you're done. But when you're looking at the long term and the risk of complications, and particularly Asherman syndrome, that's something that fertility specialists were terrified of. So what if you're not a patient at Markham Fertility Center? If you are experiencing miscarriage, if you've had a recent miscarriage, and let's say the pregnancy tissue passed spontaneously,
It's really important to have follow-up to make sure that everything has passed. And again, that could be an ultrasound or it could be blood work. You could access care through your family doctor or a walk-in clinic, or of course, there's always the emergency room as well. Some hospitals will have an early pregnancy clinic, such as Markham Stouffville Hospital, where they have a dedicated clinic where they will send patients for this type of follow-up care. But it is really important to make sure that everything has passed. Expectant management is totally a reasonable option, but we can also try medical management a few times. So, sometimes we will try methylgynezo. If there's still retained tissue, we may try misoprostol again. As fertility specialists, we know that the risks with retained products of conception are real and they can have long-term consequences. And this is why it really does require close follow-up and some kind of testing, again, whether it's blood work or ultrasound, to ensure that everything has passed.
Okay, so we're switching gears now. We want to talk about something called Rogam. Rogam is a medication that is given to women after having a miscarriage when they are Rh negative. I'm going to explain who requires this medication and why we give it. There are two types of rhesus factors for humans. There is Rh positive and Rh negative. So that just has to do with whether or not there is the rhesus factors on the surface of your red blood cells. If you have it, you're Rh positive, and if you don't have it, you're Rh negative. If a person carrying a pregnancy is Rh negative and the person providing sperm is Rh positive, the fetus might either be Rh positive, like the sperm provider, or Rh negative, like the egg provider. If the person carrying the pregnancy is Rh negative and the fetus is Rh positive, that's a situation where Rogam is necessary in some cases in the first trimester to prevent alloimmunization. So if the fetus is developed enough to have the Rh factor in the fetal blood, the person carrying the pregnancy's immune system can recognize that and create antibodies. These antibodies will stay in the blood for a long time and can not only affect the pregnancy in question, but most importantly, because in this case it might have been a miscarriage, but those antibodies can actually remain in the blood and affect a subsequent healthy pregnancy. So this is why it's important in situations where there is a miscarriage, at a gestational age, when the fetus has developed the Rh in the fetal blood, to give Rogam to the person carrying the pregnancy to prevent alloimmunization and develop antibodies that can affect a future fetus. Now, how do we know that the fetus in question has developed the Rh factors? It depends on the gestational age.
Generally speaking, if the fetus has developed to approximately 8 weeks of pregnancy and a miscarriage has been recognized, then it can be considered to give Rogam to prevent alloimmunization.
Pregnancies that result in a biochemical pregnancy, that means the embryo implanted, but there was no ultrasound noted and the pregnancy level dropped quickly, do not require Rogam. Pregnancies where the embryo has implanted and the ultrasound shows that the pregnancy never grew past the 7-week gestation and there was never a heart rate noted, do not require Rogam. So Rogam is indicated in pregnancies that made it past the 7-week gestation in terms of the size of the fetus. And it's also indicated if the pregnancy is ongoing and there is a large bleed, for example. It's also indicated at 28 weeks of gestation in a healthy pregnancy. And it's also indicated in the postpartum period if we have a baby that is born who is Rh positive and is born to an Rh negative mother.
It's important to note, though, that Rogam is given in many situations, even for people who've had biochemical pregnancy or in situations where people have had a pregnancy where the pregnancy ended much earlier than 7.5 weeks. Now, this is not wrong to do. Rogam is generally considered extremely safe, and I would say that most physicians have a very low threshold for giving Rogam because the risk of giving it is extremely low, but the risk of not giving it and then causing alloimmunization can be very devastating down the line. And so most physicians generally have a very low threshold for giving Rogam.
Yes, I am guilty of that.
Oh, absolutely. And I don't think it's anything to be guilty about, right?
It's better to have a too low threshold than too high threshold. But it is actually really interesting is when I was researching for this episode, when ROGAM is given and when it's not given varies a lot depending on the country and what the body of regulators say.
In Canada, the Society of Obstetricians and Gynecologists of Canada actually released a brand new guideline specifically talking about the administration of ROGAM for patients who have undergone a miscarriage or had an ectopic pregnancy or a molar pregnancy. And it's actually quite a bit of change since the previous guidelines that were published in 2018. So right now in Canada, at the time of recording in January of 2025, the guidelines state that really for patients who are earlier than 8 weeks of pregnancy, and that's determined based on ultrasound size, ROGAM is not recommended at this point. Now, between 8 and 12 weeks of pregnancy, they also do not recommend administering ROGAM. And this is a big change. This is a big shift since the 2018 guidelines. Now, they do mention that between 8 and 12 weeks, you can consider giving ROGAM, and they say, quote, in individuals who are more risk averse in that specific group. What's interesting is that in the US, when we look at the guidelines from the American College of Obstetricians and Gynecologists, they have previously said no ROGAM before the first 12 weeks of pregnancy at all.
Another important thing about ROGAM is that this is not just like a regular medication. So if you are having a miscarriage and if you need ROGAM determined by your doctor, then most likely you're going to have to visit a hospital because it's only available at hospital blood banks because it is a blood product. That might mean that you need to go in through the eMERGE potentially to get this ROGAM injection done. Or again, here at Markham Stouffville Hospital, we have access to the early pregnancy clinic where we can set patients up for an appointment to get ROGAM. This is not something that we have here at the clinic and not something that you can pick up at our pharmacy. Also, ROGAM doesn't have to be given at the exact time that you're diagnosed with a miscarriage. So sometimes it's okay if it happened on a Friday to come on a Monday or to come the next day to get the ROGAM. That's perfectly safe as well. And another thing I wanted to mention about ROGAM is I mentioned it's given to Rh negative people who are carrying a pregnancy. But if we know that the sperm provider is also Rh negative and that the egg provider is Rh negative, and the person carrying the pregnancy is Rh negative, then there is no need for ROGAM because as long as the baby has the same Rh type as the person carrying the pregnancy, there is no risk for autoimmunization, even if the person carrying the pregnancy is Rh negative. So now we're going to address some of the questions that we commonly get when it comes to miscarriages. The first question is, why did this happen? We talked about this in episode 43, so don't forget to refer back to that one. Generally speaking, the most common cause of miscarriage is chromosomal abnormalities of the embryo, which means this is not something that you did. It is very common for patients to blame themselves, to go over everything they've done over the last week and question if it was the stairs, what they ate, what they didn't eat, how little they slept, their worry, the stress, their anxieties that caused the miscarriage. And I'm here to reassure you that it's nothing that you did wrong. There are multiple causes of miscarriage, the most common of them being simply that the embryo was not genetically normal. Like I mentioned in episode 43, we talk about that in more detail. And we even talk about how to test the process of conception to determine if that was really the cause of miscarriages or not.
Another common question that comes up a lot is, do I need further testing to figure out why this happened? This really depends on a person's previous pregnancy history and fertility history. Is this the first miscarriage, or is this the second, third, or fourth miscarriage that a person has had? Was this a spontaneous pregnancy, or was this a miscarriage that happened after, let's say, a frozen embryo transfer of a euploid embryo? All of these things can affect the risk and kind of give us a better idea whether further testing is needed. Really, it's best to speak with your physician to see if they feel like further testing would be advised. Generally speaking, it's best to see a fertility doctor for discussion about testing for recurrent pregnancy loss. So again, looking for other reasons other than genetics, other causes of miscarriage after 2 to 3 miscarriages. Now, they don't necessarily have to be in a row. And again, we're going to have a full episode that will come out about recurrent pregnancy loss, and all the investigations that we do will be upcoming.
Another common question is, how long until I get my period back? And generally speaking, the first period can happen about 4 to 6 weeks after miscarriage if you had regular cycles prior to a pregnancy. The first period might not be exactly the same as your other cycles. It might be a little weird, it might be heavy, it might be long, or it might be short or light. The subsequent periods after that should go back to your baseline, whatever your normal menstrual cycles look like.
Another common question that we get all the time, when can I start trying to conceive again? When we're thinking about the patients that we're typically seeing, they are fertility patients where time is often of the essence. First of all, most important thing is to confirm that there is no more pregnancy tissue. If somebody starts trying to conceive again while there's pregnancy tissue still present, then they may not conceive because the body may not be ready. The body may not go back to ovulating when pregnancy hormone is still present. And if there is pregnancy tissue in the uterus, it may potentially increase risk of miscarriage and cause further issues down the line. In a situation where we know that there is no more pregnancy tissue and that the miscarriage has for sure completed, then people can start trying to conceive again after their first period.
You might also be wondering, after having a miscarriage, what is my chance of a miscarriage happening again? This will depend heavily on the age of the egg, because that is the number one predictor of miscarriage rate. We talked about that on episode 43. We went over the miscarriage rates based on the age of the egg, so you can refer back to that. We also know that after having a miscarriage, you're going to have increased levels of anxiety. We expect that, and we're prepared for it for your subsequent pregnancy. I tell all of my patients every new pregnancy is a new egg and a new sperm in a new part of the uterus. So we treat every new pregnancy like the potential for a baby that it is, while understanding that having had a prior miscarriage does make you more anxious and worried, and that's completely normal. Now, the actual risk of repeat miscarriages is only slightly higher after having one miscarriage. The risk is mostly dictated by the age of the eggs as opposed to a prior history of miscarriage.
And last but not least, another question that comes up periodically is a patient may say, I've had my period after my miscarriage. That must mean that everything has passed, right? Well, it's not really that simple. Certainly, if there was a large amount of retained tissue and the pregnancy hormone was still high because of that tissue, then the periods don't come back. That being said, you can have bleeding secondary to the presence of retained products. Because as we said earlier, when there's retained products there in the uterus can't contract down completely. You can have irregular bleeding, spotting, or even very heavy bleeding. And sometimes this can be mistaken for a period. In speaking with a patient, in talking about the amount of bleeding that they had or the amount of clots they had or whether they feel like tissue passed or not, we as fertility doctors do not know if somebody has had a complete miscarriage. There is really no way to know for sure based on someone's experiences in terms of how much bleeding or how much cramping they had. And so really, it's so important to not try and self-diagnose or try and figure out based on symptoms if you've had a complete miscarriage. It's very important to get an ultrasound done or blood work done to really confirm that it was a complete miscarriage and everything has passed. Because if, as we've said several times in this episode, if there is retained tissue, there can be serious complications over the long term, which can be really difficult to deal with. At the beginning of this episode, we started with this question. Your doctor has confirmed you've had a miscarriage. What's next? I really hope that this has been helpful to patients and has really explained the different management options and where to move forward from here. If you remember nothing else from this episode, please know that this is not your fault and that a miscarriage is not the result of something that you did or something you didn't do. And that even though there's always a risk that a pregnancy can end in a miscarriage, the chance of your next pregnancy being successful and going on to produce a healthy baby far outweighs your risk of miscarriage in the future. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.